Okay, the last congenital anomalies we're going to talk about are the 3 cyanotic lesions with increased pulmonary blood flow. As we see this, what we have is we have systems that fail to develop into a separate pulmonary and systemic circulation. So we don't have one side going to the lungs and the other side going out into the rest of the body like we normally do. We do have one where there is reversal of circulation. So what we have is saturated blood going to the pulmonary circulation and unsaturated blood going to the systemic circulation. With all of these, we have a increase in the cardiac workload. The ventricles are working much harder. We're increasing the workload of the heart. By increasing it, we're not increasing our cardiac output, but that has been decreased. The 3 we're going to talk about are truncus arteriosus, hypoplastic left heart syndrome, and transposition of the great arteries. Truncus arteriosus. What happens is in utero, we have a pulmonary artery, which is right here, and an aorta. What happens in utero is it's all one. These are one large artery. At some time during the fetal development, these arteries split into 2, where the pulmonary artery comes off the right ventricle and ligaments form, and the aorta comes off the left ventricle and we have ligaments form closing it up from the right ventricle. What happens here is they fail to split off into 2 separate main arteries. So we have an incomplete division of the great vessel. The truncus arteriosus does not divide into the pulmonary artery and into the aorta. As you can see from this, what we also have is a large VSD that is present. You can see that right there. So we've got one outflow valve. One valve goes to the lungs. One valve goes to the systemic circulation. They are not divided into 2 separate valves like they should. The ventricles become overloaded and we have decreased cardiac output and decreased perfusion to the coronary arteries. The infant will be in heart failure. There will be profound cyanosis. There will be bounding pulses and a widened pulse pressure. Often these infants have DiGeorge syndrome. DiGeorge syndrome causes a decrease in the immune system, so we have frequent infections. These infants are prone to frequent respiratory infections. We have hypocalcemia that occurs. That's part of DiGeorge syndrome, and hypomagnesemia that occurs. The main goal is we want to prevent polycythemia from occurring with this deoxygenated blood that's going out there. For survival, what we have to do is keep the PDA open, so that our hopes is that some of that deoxygenated blood will go back to the lungs to be oxygenated and then get back out to the circulation. When the infant is old enough, they're due surgery to split the truncus arteriosus into the 2 main arteries. Next one we have is hypoplastic left heart syndrome. With the hypoplastic left heart syndrome, as you can see, the left ventricle does not form. So we do not have a left ventricle. Most of these infants die within the first few months of life if it's left untreated. The infant will go into heart failure, have severe tachypnea and dyspnea, hypotension. They have acid-base imbalances, electrolyte imbalances. What they need to do is give PGE1 to keep the PDA open. These infants will have the bluish gray color. Sometimes them will even go into shock. A lot of times for survival, a heart transplant is needed. But how often do you think there's an infant's heart available? They do have staging where they can do surgery, but usually if they do surgery on these infants, Survival is not more than 4 years of age. Last one we're going to talk about is transposition of the great vessels. This is more common in males than in females. Almost half of them have an existing VSD that occurs, and as you can see at the bottom picture, you can see the huge VSD there. Right ventricle gives rise to the aorta, left ventricle gives rise to the pulmonary artery. So off the right ventricle, we've got the deoxygenated blood flowing into the systemic circulation. Off the left ventricle, we got oxygenated blood going back into the lungs. Main thing here is we want to keep that PDA open. We give them PGE1, and we hope that some of that deoxygenated blood off the aorta will go back down and go into the lungs. Survival depends on the foraminal valley and PDA. Usually these infants will have profound cyanosis. Minimal response to oxygen we see with these. And what they will do when the infant is old enough, they will actually switch the two, do surgery to switch them. Nursing interventions for all of these kids is, all of them with cardiac defects will be to avoid situations that will increase cardiac demands. That is why we only feed them for no more than 30 minutes. We have them have frequent rest periods. Weighing them daily is very important because many of them have failure to thrive. A lot of these kids will be given digoxin because of the heart failure. We need to increase the strength of those contractions. They're beyond diuretics. Again, we don't want to give the, they're beyond digoxin. We don't want to give the digoxin unless they have adequate cardiac output. Again, monitoring their potassium levels is very important. Adequate isonos. Actually, when they are home, the parents actually do weigh the diapers on a scale, and they determine what their output is. It's very important to keep track of that for these kids. O2 at the lowest dose necessary. Remember, oxygen is a vasodilator, so they don't want to give them high doses of oxygen. If the patient is to have cardiac surgery, mainly they come back with chest tubes post-op. Fluids and electrolytes, there's a nice balance between that they have to maintain. They're going to have an increase in their aldosterone and ADH release, so we're going to have edema with these kids. They lose potassium during surgery. Even the stress of surgery is going to increase their PTH, and they're going to become hypocalcemic. We want to promote comfort in them, promote healing and recovery. With these kids, we don't want them to be exposed to outside sources and to chances of infection if we can help it. A lot of these kids will have limited activity until the cardiologist feels that they are strong enough. And that ends the PowerPoint.